Well, good morning and welcome to GIM Grand Rounds. This is one of our special Grand Rounds. This is the Meiklejohn Memorial Grand Rounds, and you'll see on the slides a picture of Dr. Gordon Meiklejohn. Dr. Meiklejohn was essentially the founding department chair for the modern Department of Medicine. You can see some of the highlights in the slide. He was recruited in 1951. He built the department at the time. I think there were 7 or 8 faculty members. He, in essence, built all of the current, not all, but almost all of the current divisions. When he passed away in the late 90s, an endowment was raised, and that endowment was given to our division, which we've used every year for to bring a national speaker of great renown. That's what we're gathered today to do. We have Dr. Sandy Springer, who's here from Yale. Dr. Springer began her career at Harvard, where she got her undergraduate degree. She went from there to the University of Massachusetts, where she attended medical school and did her internship and residency in infectious diseases at Yale, where she's on the faculty. Her clinical interests are at the intersection of infectious disease and addiction, and that's also where she does her research. She's been continuously funded by the National Institutes of Health for almost 20 years, including an Avant-Garde Award from NIDA in 2022 for innovative work that she did, again, at the intersection of HIV and substance use treatment. She has a number of national and international appointments, including to the International AIDS Society and USA Antiretroviral Guidelines panels. She has had a couple of appointments at the National Academy of Sciences, Engineering, and Medicine, including the Committee on the Integration of Opioid Use Disorder and Infectious Disease Treatment, and a current appointment to the Committee on Chronic Conditions Among Women. She's also appointed to the American Society of Addiction Medicine Criminal Justice Guideline Committee. On a more personal note, she's the mother of 3 children, ranging in ages from 13 to 21, and in an alternative life would be a star of a culinary reality show, probably. So is an avowed foodie and outdoors enthusiast. So please join me in welcoming Dr. Springer with us today.
Let's see. Thank you very much. Oh, yes. Oh, okay.
Nope.
Thank you.
You're very welcome.
Thank you. Thank you very much. And thanks. I can't say enough about the honor of coming here and inviting me. And I hope, everyone that I think people need to know that I also have imposter syndrome. So, I hope that you come away with understanding why this means a lot to me. And whatever you take from this, maybe one iota, maybe you don't want to integrate infectious disease and substance use disorder treatment, but you understand the reasons for why we should be thinking in that way. So these are my disclosures. The learning objectives, I'm not going to read through them, but really just coming away with understanding the importance of understanding this, the reason for this topic, and hopefully coming away with ideas about how to integrate substance use disorder treatment, including medications for opioid use disorder, long-acting forms in different settings, and how to bring services to people. So I'm going to start with a brief clinical case, probably familiar to many of you. This is at Yale New Haven Hospital where I'm at. 28-year-old woman recently hospitalized with MRSA bacteremia, septic knee arthritis, wound infection with associated cellulitis, started on antibiotics. She acknowledged injection of fentanyl and xylazine. So in Connecticut, xylazine isn't just a contaminant, it's also a drug that's very sought out. And she was unhoused, living on the couch of a friend currently, and she lacked transportation. She was told to stay in the hospital to complete her 4-week course because she was actively injecting, so they wouldn't discharge her. But within 4 days of her hospital stay, she self-discharged. So this idea is there's something else we could have offered her in this clinical setting that might have helped her stay or maybe an alternative option for how she could have completed her infectious disease treatment, and also consider her substance use disorder treatment. So this is just a composite here, but just to put it all in one slide, we know the substance use is an epidemic in this country. And I just want to report, this is data from the National Survey of Drug Use and Health data. And of course, it's underreporting because this is predominantly assessing individuals who are housed. So the numbers are much higher in those who are unhoused and those who are involved in our criminal justice system. But about 70 million were reporting illicit drug use, which is pretty remarkable that they're reporting it. And then about 50 million had a known substance use disorder, DSM, Diagnostic Statistical Manual substance use disorder, and about 3 million with an opioid use disorder. And again, we know that's underreporting. And about 1 in 5 are on effective medication treatments for opioid use disorder. Again, that's of those who are housed. And the numbers are far worse of those who are involved in the criminal justice system and those who are unhoused. And although you don't have to have a substance use disorder to die from overdose, we do know that there's a significant number of individuals who are dying in this country. And as of the end of 2023, and this is the CDC just reported this data a couple of days ago, around 103 to 107,000 deaths at the end of December of 2023. This is just a composite to show the waves of the substance use epidemic that you're probably familiar with. Starting with the early prescription opioid epidemic in green, not the problem now, it's not prescription opioids, was quickly followed by black tar heroin coming from Mexico in 2010. But now, not our problem. It's really hard to find, especially in the East Coast, heroin. And when people report heroin, it's not heroin. But the big problem, of course, was in around 2013 when the synthetic opioids started coming around, mainly fentanyl, and other analogs, and have really driven our overdose deaths. But just to remind you, although my talk today is going to be mainly around opioid use disorder, I think it's really important to know the fourth wave, we call it, which is the stimulant epidemic that really hit hard in around 2014, 2015. In isolation alone, stimulants cause overdose deaths. I think a lot of people don't know that, around 40% or so. But in addition, you put fentanyl with that. You can see that's really driving overdose deaths. My neck of the woods in Connecticut, it's cocaine. We're the main supplier of the East Coast. And I know up here it's methamphetamine and mainly most areas. But, it's not just substance use on its own that's causing morbidity and mortality. It's also fueling other medical conditions. And for me and a lot of us, and what I just showed you with this case, it's also fueling new infectious disease epidemics. So this is older data, but I always like to show it just because it was a lot of individuals, over 36 million people, really showing in that early phase from 2002, the prescription opioid epidemic going to the heroin epidemic, this rise in hospitalizations that we've probably all of you have experienced as well as I have, of individuals who are admitted with what was used to be called opioid dependence or opioid misuse, and serious bacterial infections, infectious endocarditis, osteoseptic arthritis, et cetera. Also, acute hepatitis C was rising, mainly, unfortunately, in our younger populations following this opioid injection epidemic, which then led to a change in our guidelines, right, for screening hepatitis C. And then HIV. So this is not a conclusive slide, but just to point out that HIV outbreaks are occurring in this country in multiple areas, in Medicaid and non-Medicaid expansion states. It really, although we remember our early HIV epidemic, it was pretty quiet up until Scott County, Indiana, and that one was related to a prescription opioid, oxymorphone, but in a very rural area, Scott County. And I went out in 2015 to talk to the then Lieutenant Governor and others. There was a moratorium on syringe services. There was a lack of methadone expansion, a lack of Medicaid that then Governor Pence had decided. And then you have this rural area derived from Appalachia, lack of transportation, really was just unfortunate, and whole families really developing HIV. But since that time, it's really been driven by, was originally heroin, fentanyl, and stimulants. And even in Massachusetts, north of me, where I used to live near Lowell and Lawrence, which was a former mill town, a lot of individuals who are unhoused. Again, that mayor had put a moratorium on syringe services too. And it was really difficult for people to find access to treatment. But people aren't getting access to services. And I think this is really what's driven a lot of my work. In general, I think we know this, infectious disease and addiction have been siloed. And I really believe that without integrated care, we're not really going to reduce infections or overdose deaths. And, it's not just me saying this. So there's lots of folks, including Dr. Josh Barakis is here, other infectious disease doctors who've been calling for this for some time. Ellen Eaton at University of Alabama, Nick Savelle, who's at Yale and now at Drexel, really trying to identify and help infectious disease and other physicians to know what substance use disorder looks like. And it's not just us individually, it's whole organizations, Infectious Disease Society of America, HIV-MA, really coming together. Drs. Hermione Hurley, who's here at Denver Health, Dr. Barakis and others, and many other ID doctors across the country, really recognizing that maybe not just us, but strengthening collaborations between addiction services, addiction psychiatry, addiction medicine, other programs, improving training could improve these coalescing epidemics. And it wasn't just that, it was the Department of Health and Human Service who tasked the National Academy of Sciences to do a study in 2019, 2020 to say, what can we do? And so I was appointed part of that panel and really led to a very detailed strategic plan, which included removing the X waiver for prescription of buprenorphine and other things. This is just a composite of that. There were other things going on in that early time of 2020 that I think took precedence, but really just this idea that we needed to do more and we couldn't be living in silos. This is just a summary slide, and I'll be talking about mainly HIV and the association of substance use. But just to remind us, it's not surprising, right? Especially with the early HIV epidemic, that ongoing substance use includes alcohol. There's even some data for nicotine. It's not just opioids and stimulants can increase risk of acquisition of HIV through increased condom sexual intercourse and injection drug use risk. But we have to remember among individuals who have HIV that ongoing substance use can interfere with the antiretroviral care cascade and then lead to a lack of adherence. And then unfortunately, increase in HIV viral load. Our goal is viral suppression. And then of course, for the individual, increased morbidity to that person. But from a public health standpoint, if we cannot help individuals maintain viral suppression and they partake in high risk behaviors, there's an increased risk of transmission to others. So that undetectable equals untransmittable. We really need to help individuals stay on care. So I'm not going to really talk too much about it, but my whole early career was on the classic biomedical interventions to improve HIV. And really, though, the culmination of it was showing that if you started treatment to prevent relapse or treat opioid and also alcohol use disorder in individuals with HIV, that besides reduction in substance use, we could see an improvement in an infectious disease outcome. We could see an improvement in HIV viral suppression. And that's what all of this work did show. And this idea that medication treatment for substance use disorder could be a treatment as prevention. This was earlier data where we looked at just the initiation of a medication, buprenorphine. And just to let you know, this was started when buprenorphine, just after buprenorphine had been approved for non-licensed opioid treatment providers, someone like me, to prescribe. So nobody had heard of buprenorphine. And so I was just interested, I could finally treat opioid use disorder. I had to always refer to methadone, but could we take individuals, and I was working in the prisons and jails at that time as an ID fellow and was curious, could we start buprenorphine to help improve HIV viral suppression before they got released? It was just a non-randomized control trial, and individuals who started buprenorphine when they got out of prison and jail, some of them mean incarceration period for a year, asked them if they wanted to be on buprenorphine. Never heard of it before, or not. And if they didn't, we could also help refer them to methadone. And the individuals, it's a small cohort, only about 100, who started buprenorphine and maintained on buprenorphine for 6 months, were able to maintain viral suppression at less than 50 copies compared to those who didn't retain and those who were not on buprenorphine, including methadone. And this set up the quintessential double-blind placebo-controlled trial that you had to do, and it was with the first FDA-approved injectable form of treatment for opioid use disorder, which was extended release naltrexone, again, in individuals with HIV, and in this case was opioid dependence. I wrote opioid use disorder, who were coming out of prison and jail, starting before they got released and then continuing in the community. Again, no one had heard about extended release naltrexone for opioid use disorder, and the prisons and jails would only accept an opioid antagonist treatment. But the bottom line was, at 6 months, if you could, the individuals who started on medication and continued in the community, remember they weren't using, they were incarcerated, were able to achieve viral suppression compared to placebo. We did the exact same study design in individuals with alcohol use disorders and HIV, also coming out of prison and jail with the same form of treatment, which is FDA approved for alcohol use disorder, found the same thing, even more robust outcomes actually. And that treatment to prevent relapse can improve the likelihood of adherence to antiretroviral therapy and maintenance of viral suppression. So this idea that if we could integrate and help identify patients early, that we could improve not just substance use outcomes, but an HIV outcome was really important. In 2022, the International AIDS Society USA panel, for the first time, asked for substance use disorder recommendations for people with HIV and at risk for HIV. So myself and Ellen Eaton at University of Alabama were asked to represent the substance use disorder group, and it was lovely. It was nice to be a part of guidelines that said, yeah, we should be providing diagnosis, we should be providing treatment. We even talked about contingency management for stimulant use disorders. And then some things at the bottom here that I'll probably talk about more at the end of the talk, and then the Department of Medicine talk tomorrow about how to help people get access to these services and stay on services, which is really cool. I was like, oh, this is nice. But the reality is, despite all of that, and despite this awesome Ending the HIV Epidemic plan that we have, I don't know how many are familiar with the Ending the HIV Epidemic plan. Okay. So grounded in a lot of science that I'm not going to be able to go into, despite all of this, really a complete, just forgetting the individuals who use drugs. There's a little bit in here for certain services, but really not even thinking about how we're going to identify individuals and offer treatment. It's like all those papers you do and you're like, no one really listens. But the first pillar is, yeah, we should test everybody. HIV, diagnose, get people on treatment, not just start treatment for antiretroviral therapy sometime, but rapidly. There's a lot of data, including RCTs, that are showing if you initiate treatment on the same day as a rapid HIV test or within 7 days, that it improves the likelihood of viral suppression and staying in care. So we need to rapidly start people on. You don't have to do any fancy tests. You don't even need to wait for the viral load. Then if they don't have HIV, initiate what we call pre-exposure prophylaxis or PrEP to prevent HIV. There's 3 FDA-approved medications, 2 oral, 1 injectable form, all work at reducing HIV. And then for those who are sharing injection drug use equipment, offer syringe services. Tons of data, right, that show reduction in HIV acquisition. And then respond. So you got to know before it happens where these outbreaks could occur and hopefully prevent that. And that's a whole nother thing that Dr. Barakas and others are working on, but really hard to do when you don't have the data, especially when the CDC data lags behind about 3 years. And then the goal is to reduce new HIV infections by 90%. But again, lack of implementation plans. So I know maybe you guys know where to get an HIV test, but think about other individuals. How do I know where to go to get an HIV test? And it's not just once, multiple times. If you don't have insurance, how do you get PrEP? And you need to get labs every 3 months. And we're not on target. So we're supposed to be down to 9,300 cases by next year. And as of the last CDC data, we had 32,000 new infections in this country. And although I know that persons who are injecting drugs is not the main risk group for acquiring HIV, it's still a major concern. So how do we approach this intersection? So I'm not going to talk about what I've been doing since those early trials, which was I started out with more translational science, working with bench researchers, can we see if these treatments for opioid use disorder actually improve HIV latency and other immune outcomes? But really at the intersection of multiple areas, like hospital settings, the carceral system, and in the community, of how we can approach this intersection and not just do these standard trials of biomedical interventions, although some of them are, but really thinking about how can we help individuals get access to these services. So one is, as I said, you need to know, you need to screen, you need to diagnose, you need to be able to provide treatment. And if you don't know how to do it, you need to find somebody in your community, and you need to know in the moment. So if you're going to screen, if you're going to do a test, like we say this all the time, right, in medicine, what are you going to do about that test? What's the point of doing a test if you can't do anything about it? And then not just initiate, but help people stay in care. This is just a few of, I'm an ID and addiction physician, take care of patients, and I can clearly say in our hospital setting, I also am a VA doctor, or VA setting, and I know many do not have universal screening for substance use disorder, or even screening diagnosis. And then there's, it's the same, also, if you look at different settings, there's a lack of treatment for, if you're in a substance use disorder program, a lack of people who provide PrEP. And if you're in an HIV setting or an ID setting or ID office, a lack of individuals who feel comfortable with treating substance use. There's lots of stigma. There's more stigma in my colleagues and other healthcare providers about substance use than HIV that I've ever seen. It's like a decision. I actually could talk on and on about this. And then there's resources are poor and experiences insufficient, but that screening, you got to know, you have to know. And how are you going to know if you don't ask? So if anything, you come away with this, you may not feel comfortable with treatment, but just asking and helping people get access to care is really critical. So this is well-known: screening, brief intervention, initiation of treatment, SBIRT. I said, I added medication treatment. And instead of referral, I said initiation added down there, but harm reduction programs, gray areas, syringe services. We should be screening for substance use disorder and HIV, jails, other settings, emergency rooms, inpatient hospitals, specialty and primary care setting. And we should be able to provide treatment. So this is from NIDA, Nora Volkow and colleagues about measurement-based care. So diagnosis should lead to treatment, importantly, about opioid use disorder, not just screening, but actually diagnosis, so that you can rapidly start treatment similar to a rapid antiretroviral therapy. These are how do you diagnose substance use disorder? Not everybody knows or memorizes the DSM diagnostic criteria. So I think it's rare that we see people doing a DSM-5 assessment in individuals, maybe our psychiatry colleagues, but it's 11 symptoms, and you have to have 4 or more to be prescribed opioid use disorder treatment, so moderate to severe. So what I realized early on when I had my K with that early buprenorphine study, and I wanted to find individuals who are being released with what was then called opioid dependence. I was like, there's no rapid diagnostic tool. How am I going to identify them? How am I going to know to meet with them? So we created something that later turned out to be called this, for non-clinicians to use to rapidly diagnose, not screen, diagnose opioid use disorder in less than 3 minutes. And that's been used by multiple people to initiate. Who knew? That's another thing about research. You have no idea what's going to come out of it. I never had the intent to do this, but that could initiate buprenorphine, extended release naltrexone, extended release buprenorphine in multiple settings. And then last year, Angela DiPaola, who's a postdoc with me, created a new one for the DSM-5 for moderate to severe opioid use disorder. And we created a brand new one for stimulant use disorder so that we could identify people early on. And again, non-clinicians, it was validated, published, and comes to a rapid diagnosis. So I'm constantly thinking about, if I want to help people get into treatment, we need to help individuals be able to do that. So these are free tools. That treatment, I'm not going to spend a lot of time, but for opioid use disorder, we are lucky in the United States that we have 3 effective FDA-approved medications. Some countries don't, right? Russia, you can't have any opioid agonist treatments. You can only have naltrexone. But methadone's been around for a long time, unfortunately, in this country, until we have some legislation change. It has to be dispensed in a licensed opioid treatment program. You cannot prescribe it yet unless for opioid use disorder, unless you're in one of those programs. Buprenorphine and extended release naltrexone, however, you can. And buprenorphine no longer an X waiver. You just, if you have a controlled substance license, you just have to do 1 8-hour training. You know about that, right? The May Act, and anyone can prescribe buprenorphine. And it comes in multiple formulations, including, as I'll talk about, an injectable form of medication that can last 30 days. And then, of course, extended release naltrexone. They're different at their mechanisms of action. So buprenorphine is a partial opioid, extended release naltrexone, a complete blocker, antagonist, and methadone, a full opioid. But in addition, all three reduce craving for opioids and reduce use. And it's important to know they also reduce risk behaviors for HIV and hepatitis C. And as I showed you early on, work that showed that it can improve other outcomes like viral suppression, also hepatitis C completion and cure, et cetera. This is just a summary slide. The key is, especially buprenorphine, it's one of the best advances in primary care, reduces death. It's amazing. It's one of the best things that's happened, I think, since hepatitis C cure treatment. But also improve psychosocial outcomes. And then because buprenorphine and methadone are opioids, they also can co-treat pain and relieve opioid withdrawal. The big problem we have, though, is a lot of the individuals can't maintain on treatment. So we have poor retention. If you look at any of the clinical trials, they're all similar in terms of poor retention. Any lack of retention can lead to death. We know that quickly when people stop treatment, the risk of death is high. And then, of course, if we're thinking about infectious disease, HIV, hepatitis C, they can lack access to, with ongoing use, increase interruptions in their care. So there are new long-acting formulations, and I'm going to talk a couple of minutes about that and how I think they could help improve outcomes, not from just substance use, but also infectious disease outcomes. We have 2 FDA-approved monthly formulations. In our hospital, Sublocade is on the formulary. Also in the VA now, Sublocade's on the formulary, and Brixadi, they're just adding to the VA formulary, and I think it's coming on Yale. But long-acting forms that could help improve that retention aspect. Really cool. These are what they look like. Sublocade is in the abdomen, subcutaneously injection once a month in 2 formulations. And then Brixadi can be administered kind of anywhere, arm, buttock, and very similar to the dose of sublingual buprenorphine, can be weekly or monthly. And so some of the areas that I've been working on that I'm thinking about, especially in those that are high risk for HIV or living with HIV, hospitalized patients, also with concurrent infections, veterans who have a higher risk of opioid use disorder, persons who are being released from prison and jail, and of course the unhoused, and there's a lot of overlap, of course, with all of that. Hospitalized persons, so I'm just going to briefly talk about a study that we have in individuals who have concurrent infections and opioid use disorder who are hospitalized. So why even think about this? I think y'all know, and I was hinting at it from the first case, right? Could a long-acting form of buprenorphine that had been instituted in the hospital help an individual not only retain on treatment in the community, but also help them, if they have a concurrent bacterial infection, improve their likelihood of antimicrobial treatment, reduce self-discharge, and reduce readmission. So it's called the COMMIT trial, and it just completed April of this year, but it was a randomized controlled trial in 3 sites comparing this integrated long-acting form of buprenorphine, in this case, Sublocade, with a nurse care model in patients who are hospitalized with opioid use disorder and infections, compared to treatment as usual. And the primary outcome was MOUD at 3 months, medication treatment for opioid use disorder at 3 months. It was conducted in Pennsylvania, South Carolina, and Connecticut, and a 12-week intervention with a 24-week final visit. And you can see, in addition, we had opioid outcomes overdose, as well as antimicrobial outcomes being evaluated. And everyone was randomized 1-to-1. The challenge was, and I'm hinting back, that how do you identify people? So if you have your research hat on, like I was talking way back when I was trying to find people in prison and jail, there's no universal identification of opioid use disorder there. So I had to create something. In the hospitals, it's also challenging. Do you guys have universal opioid use disorder screening for everybody who comes into the emergency room that gets hospitalized here? No. So you have to ask. And so we created this very detailed plan, and it's actually in the protocol paper. You can download how we did this, but running lots of we had Epic, so we could link lab data with diagnosis codes, other things, generating lists, using some ICD-10 codes, but they're not great, right? Because not everybody knows you have opioid use disorder, but looking at infections, of course. And then other things. What other things do individuals who use drugs might be admitted for if they're not being diagnosed with opioid use disorder? Constipation, altered mental status, hepatitis C, unintentional poisoning, history of overdose, suicide attempt. So we did that, and then we would go to the bedside and do the rapid diagnosis for opioid use disorder. We had ended up with about 175 individuals. I'm just showing you some data, and in red, I just want to point out 40% were unhoused. A good sample of those who identify as female, and then you can see depression and others are very common. And the reason why I'm talking about that, I'm going to point out that unhoused issue because that's going to come up again. So treatment alone, me offering long-acting buprenorphine is not enough, right? We have to be able to think about how are we going to retain people on treatment? They have nowhere to go. Are they going to be able to get back to us? They also had significant transportation issues. These are some of the infectious diseases that we saw. Again, probably not surprising, bacteremias, and you can have more than one. A significant number with detectable hepatitis C viral load, and then you can see other infections. Not surprising, they all had to have opioid use disorder in green to be in it, but a lot of stimulant use disorder at baseline. And self-reported substance use, we did using timeline follow back, but heroin and fentanyl. So fentanyl was being self-reported, not a contaminant at that time. This started in 2020, I think. Cocaine and methamphetamine are quite high. And then in the 30 days before they were hospitalized, you can see the mean days of use. Pretty significant, about 18 days for heroin, 13 days fentanyl, and you can see cocaine and methamphetamine. That was mainly from our South Carolina and Pennsylvania colleagues. So the challenges, and I'm not going to obviously present the data from that trial because we're analyzing it right now, and I can't present it to you yet until I get approval from my co-PIs, but we will be hopefully putting that out in June. So Josh Brock thankfully was a DSMB member for that study. So he doesn't even know yet. So one of the challenges was also, and I think, what we learned through research, I've always wanted to do a whole thing in a giant conference about, yeah, we all present our research, but the lessons learned and how that can improve implementation and care of individuals clinically. Challenges of starting long-acting buprenorphine in patients who are hospitalized with serious infections. It's not just, you see this, right? Infective endocarditis, multiple abscesses to the brain, cervical abscesses, in a lot of pain, maybe undergoing cardiovascular surgery. They need long-acting opioids for pain control, plus they had fentanyl. We felt it was really important to help and release early some of the data that we learned from this trial. And we were able to safely initiate treatment and not only start buprenorphine in people who are actively using fentanyl, but also those who might have been on methadone, 160 milligrams, as well as receiving opioid treatment, and then initiating sublocade in the hospital while they might have even been just post-surgery from valve replacement. No precipitated withdrawal. In this article, it shows how we did it and each participant, how you do it. And so the idea there was, you can do it. It's safe and you can get something on board before they release and also help them not go through withdrawal like our patient that we showed you. I just want to point out, so again, some things we learned through this study that I I think are important and identify this idea of integrating infectious disease and substance use disorder. Of the 152, we do rapid HIV, Hep C, Hep B testing on everyone, in addition to identifying their other potential infections. So 61%, and this is a current trial, Yale New Haven Hospital, Prisma in South Carolina, and Penn State Hershey, who had detectable viral load. Most did not have HIV, but they did report HIV risk behaviors. Only 57% had heard about pre-exposure prophylaxis, and only 1 was on PrEP. So remember, people who inject drugs also have sex, and people don't ask about that, but there's increased risk happening, and nobody had ever offered them PrEP before. So although our study was about initiating treatment for opioid use disorder, we did look at the 6 months that they were in. No one in the community, despite 61% having detectable hepatitis C viral load, now where hepatitis C is curable with an oral treatment, possibly once a day for 8 to 12 weeks, was offered hepatitis C treatment. And only 3 were initiating it on PrEP. So great opportunity for those who are thinking about a research project or even just a clinical opportunity to think about that. You have an opportunity. You can initiate hepatitis C treatment in the hospital, just like we can in prisons and jails. And we should be, but we're not. You could offer PrEP, but you have to think about that linkage in the community. Other populations, I told you, veterans, much higher rate of overdose. I'm sure you guys know that, than the community population. This is older data, but showing you it's pretty similar. There's another study out that very few, even if they have a very robust substance use program at the VA, it's amazing. All initiative for everyone to be on medication treatment, buprenorphine or methadone, but only 35% were on it after a year of starting it. So we actually have a trial ongoing in 20 sites across VA centers in the country, comparing long-acting buprenorphine to daily buprenorphine to see if one is better at retention on treatment as well as opioid abstinence. HIV, hepatitis C, Hep B, and serious injection drug-related infections are being assessed. Could one of these treatments be better? But it's over 900 individuals, so it's ongoing right now. Justice-involved persons, I already hinted at why those are important, right? Because, high degrees of substance use, and that was my earlier work. But overdose, Ingrid Binswanger, former, early studies showing that the #1 cause of death of all, for all people coming out of prison and jail is overdose, regardless of how long they've been incarcerated. So it's a good population to think about starting treatment on, including long-acting treatment. And for those with HIV, the early data I did way back when, and others have shown, like David Wall at UNC and others, that people with HIV, you can start antiretroviral therapy, get their viral load suppressed while they're incarcerated, but without linkage and considerations, especially for relapse to substance use, which can interfere with their HIV care cascade, they can lose viral suppression, and it can happen really quickly. And in fact, was associated with that Massachusetts outbreak a little bit there too, where people who had HIV were not able to maintain on antiretroviral therapy, leading to a lack of viral suppression. So we have a trial right now that is actually comparing 2 long-acting formulations, the extended release naltrexone to extended release buprenorphine in this population. So Josh Lee at NYU is the contact PI, and then it's in 6 states, and really looking at, are one of these forms of treatment better at retention for justice-involved individuals? We're also looking at HIV and hepatitis C outcomes. And in Connecticut, we have peer navigators that link everybody to services, and these are 2 that Ruben and Margaret, who earned travel awards at the Correctional Healthcare Conference a couple of years ago, who are quite amazing. So that study is finishing this December, so we should have some outcome data soon. But besides, and I keep hinting at this, it's not just the medication treatment, right? Despite me doing these clinical trials, we need to do better. We need to help people get access to care. And I can't say enough that this is not all of the barriers, but transportation is a major one. And even in my state, it's a small state, it's a blue state, has no public transportation system except maybe in New Haven and Hartford. But if you live anywhere else, you can't get in. And guess where most of the substance use treatment programs are? They're in the cities, especially methadone programs. Stigma, racism, a lack of housing, food insecurity, poverty, lack of providers to treat, pharmacies, as I will talk more about in my Department of Medicine Grand Rounds tomorrow, not actually providing the medications, pharmacists actually not providing the medications in the pharmacies. So just remember, when you send a script, make sure you know that pharmacy carries that medication. There's a lot of data that's especially for buprenorphine, and then long-acting forms of medication treatment for opioid use disorder, as well as HIV and long-acting forms of PrEP. So these low barrier access to services, really thinking about how can we help individuals get access to services, community health workers, peer navigators, mobile health units. One of the things I do, a mobile pharmacy, telehealth, home care models, and provision of long-acting treatments. So bringing treatment to people, that's really what I've been working at mainly right now. This is a Justice Opioid Initiative, NIDA-funded study that is actually for the first time evaluating linkage care models for access to everything, PrEP, ART, substance use disorder treatment, hepatitis C treatment, STI treatment, harm reduction services, patient navigator, so an individual person who takes you everywhere you want to go, or a mobile health unit where you get a one-stop shop and the mobile health unit comes to you with a community healthcare worker who can also help with the needs. We are in 2 sites in Texas, Dallas and Fort Worth, and then we're in 6 counties out of the 8 in Connecticut. And where it's a hybrid type 1, randomizing people to one or the other and seeing if the primary outcome is time to PrEP or ART. But also we're looking at all the care cascades, so hepatitis C, OUD, and then looking at the implementation along with it. This is our mobile health unit in Connecticut. It's got 2 exam rooms and a bathroom, a clinician and a community health worker. And we literally go to where people are. So as they're being released from prison and jail, they have to have opioid or stimulant use, or they're in the community with a former justice involvement. And we identify where they live, which includes encampments. So they may be unhoused, drive to where they are, and see if they would like treatment. And then the patient navigators meet with them as well. But prescriptions aren't enough. So I can write you a script, but can you fill it? And I think we all have to think about this. We see this all the time, right? Did you fill your prescription? Did you take your medications? And sometimes it's really hard for people to get medications. And I know maybe it might be easier in the Denver area, but it's not so in many areas, especially rural communities, or even in many urban settings. So the big idea, which I'll talk about more, but was literally to bring everything to people. But importantly, can you bring the medications and not drugs donated by pharmaceutical companies, but actually developing a retail mobile pharmacy that you could prescribe anywhere from your hospital setting, you could see them right there if you wanted to, telehealth, anywhere, and send the scripts to this unit when the community health workers could dispense to could send to the patient if they needed that. And the idea was to overcome barriers. And so we created this. This was the part of the Avant-Garde Award. It's called In Motion. And there's a full pharmacy that's associated with a brick and mortar pharmacy. There's Heather, the pharmacist. It's literally a pharmacy back there. It's like CVS and Walgreens. They can dispense everything, including vaccinations, all medications, community health workers who are trained to do blood pressure checks, finger blood glucose sticks, SUD screening, HIV, Hep C testing, and also other social needs. And then there's a clinician who's full-time there, but also telehealth access that the community health workers can bring up on their iPads when they're out in the community, and a medical technician who can draw blood and do financial navigation. That's Tahira. So to get a retail pharmacy, Sandy Springer found out after she got the funding in June of 2022 that mobile retail pharmacies are illegal. So that was, it's like, what? So nothing's ever easy. But we had support from our Connecticut Department of Consumer Protection, Drug Control, our pharmacists. I was able to help write legislation with everybody together, got our senator to sponsor the bill. It passes through. I testified, and then As of July 1 of last year, within 1 year, our governor signed it into law. So now mobile retail pharmacies are legal in Connecticut, SB 1102. And so now then we could build it, and it came and we got it in September. Then we had to go through a lot of legal stuff, but we created a QR code for people to scan to know where we were going to be. We created a toll-free number. We developed prescribing things, everything to help people do this. And then we went live in December 13 of last year. So this is it. And this is some of the community health workers. And I will talk more about it in the Department of Medicine Grand Rounds tomorrow, but we had to know where to go, right? So we had to partner with a Department of Public Health. We were able to identify Waterbury as one of the main areas, 3 towns in Connecticut that have the most overdose related deaths, most emergency room related encounters, besides Hartford and New Haven, which already had a robust services. However, I could talk about that, and that you might have services, but people can't link to services. So we're going to Waterbury. This is just the first 168 individuals. So I had 2 weeks in December, and then we looked as of April 25th, I think. So we've had 168 individuals. This is just showing you. Now, remember, this is something that's different too. For a research trial, everyone has to accept, right, what you're going to do pretty much if you do a consent form. So we're talking about a mobile hub and spoke system. So we could have HIV testing, but you may not accept it, right? So we have quite a few who refuse, but one of the ideas is this system, this mobile hub and spoke system that could be in their community, will it be a moment going forward where they might come back a later time to accept HIV testing, right? Hepatitis C testing. But we did find 10 new hepatitis C infections. Glucose and blood pressure were the 2 they liked the most, but identifying hypertension we've identified, and diabetes. Our community health workers all do opioid, stimulant, and alcohol use disorder diagnosis through the screening and identify those who have severe. They may not finish it, but they're reporting use, which is important, so we can help with harm reduction services. As of last night, we had over 400 prescriptions, but 284 prescriptions from the mobile unit, mainly high blood pressure, diabetes, vaccinations. We provide all vaccinations. It's really cool. HPV, we're going to be doing Mpox, everything. And so that's been a carrot because you can come and get your vaccinations. But big wins in just a short period of time: PrEP initiation, alcohol use disorder treatment, opioid use disorder treatment. 87% are being filled on the pharmacy. And we also have our particular pharmacy, Yale New Haven Health Pharmacy, that's associated with us, also has a philanthropic program called Dispensary of Hope, which has free medications, including insulin, which is really expensive, that for those who are uninsured, we can also help identify. You may not get the best statin or the latest statin that's out there, but helping them get the right medication if they have a condition. The medical and social, what they're asking for, a lot of individuals want the medical services, but they also could just be seeing us for other social economic support. And I think this is really critical. I thought a lot of people would accept telehealth, but that's not true. The majority want in-person visits. And I think we have to offer choice in how we provide care. So hiring 100% clinician was difficult to find, but we were able to do that. But we need more specialty care. But you can see the appointments that they're asking for. A lot of primary care, there's psychiatric care, gynecological care, other housing support. And I'll go into that a little bit more in the Department of Medicine talk tomorrow. But the whole goal of this is provide whole person healthcare. I don't know what your needs are going to be. My interests might be something different than their interests, but that's not how we should be providing healthcare. If they don't understand, we have to work at it, and it takes time, but we should be able to offer them the other things that they actually need. So I'm going to end here, because I know we want some time for questions. Just hopefully that you're coming away with this idea that it's out there. There's substance use is there. You can't predict who is using substances. We don't know our biases of who uses drugs and who doesn't use drugs. We should be asking everybody. And we should know what we're going to do. So if you don't feel comfortable with providing treatment, is there a colleague who could help you? Is there another service? Think about how we could provide HIV prevention, treatment, associated infectious disease needs, harm reduction services, thinking about overcoming some of the barriers that people need, and providing services to them. One thing that's really needed is more precise targeting of communities who are at risk. So you can know from a cost perspective, and, you know, pushing your services into areas that might be of most need. We are doing that, looking at that as well. And I'm just going to end with saying thank you to a lot of people. These are the current academic collaborators that have led to a lot of this work. A lot of folks who helped with the Avant-Garde Award, and support even from Dr. Barakis here and others, and personal support. And then I just want to acknowledge, of course, the people who we are working with and who really need our help and provide a lot of guidance. They tell us what they need, right? Every day we have to listen. Obviously the research team, the funders, and then a whole host of community partners, Department of Corrections and government relations. And that's my research group, and thank you. And I'll take questions.
So thanks for a very inspiring talk. I've got a ton of questions, but I've got some time with you later that I can ask them. Questions from the audience, and then Brandon, are you looking at the chat as well? Okay. John Kepi.
My understanding is a lot of this synthetic fentanyl on the street is laced with other drugs.
Mm-hmm.
And so people don't know they're getting it. Is that correct? They don't know they're.
Some don't, some.
Can you repeat the question? So
Yeah, so the question was, there's a lot of illicit fentanyl on the streets, and it could be laced with drugs. And the question was that people don't know that it is. In some cases, yes, and that's absolutely true. And so one of the major ones is xylazine, but benzodiazepines, others, other drugs. Then there are individuals who might think they're getting heroin or another form of, and not know that it's fentanyl, which is important for us to educate, because it's really, I don't know if you guys are seeing much actual real heroin, but for us, there's no heroin in Connecticut. So people might say or think they're getting heroin, which is a big problem too. And then there's multiple analogs of fentanyl. Remember, this isn't fentanyl coming from China. This isn't your fentanyl that you use in the hospital in your ICU. This is illicitly manufactured fentanyl, many analogs. And then they might be mixed with other drugs. There could be stimulants in there, maybe unintentional, maybe intentional, based on who's supplying it. A big one now is xylazine, and there's other drugs. So veterinary drug that mimics same thing as an opioid overdose is not reversed by naloxone. So in Connecticut, it's really being, a lot of people are searching it out and can get it. We've had multiple overdoses, including in our hospital. But yeah, there's drug testing strips, there's xylazine drug testing strips, there's fentanyl drug testing strips, but they're not great. So sometimes they miss that. But one thing that we do is listen to the community. So the community can provide a lot of guidance. They can say, hey, where I bought my drugs was this, and I felt this way. I think it has this in it. That's been helpful. So they can talk to one another. But yeah, no, it's some people are aware and some people are not aware.
I'm sorry, just to follow up. From the dealer's perspective, is that to make it more addictive so that they're more likely to come back for more, or why are they?
Well, I mean, I'm not going to speak from a dealer's perspective, but I don't think we really know. I think, they don't want to kill generally the people who are purchasing this, but it's, I don't know. There's just the way it's manufactured. In some places they're manufacturing multiple different substances or the drugs that they're getting, and they may or may not know. But yeah, it's a very complicated situation, and it's like not a one, there's not one way to really deal with that. So just obtain, like when the DEA finds a whole bunch of drug supply or stops whatever. That's not how, I mean, I hope we can help reduce fentanyl on the streets, but we also have to think about it's here, and we have to be able to help people get access to harm reduction services and treatment and educate them. So some people may not know. They only want methamphetamine. They don't want that fentanyl. And you have to say, hey, this could be there. So let's talk about safe drug use, go slow, don't use alone. Have somebody, do you know how to use naloxone? Do you have a partner? Could we train them how to use it? And then, you have to call 911, right? That's the first thing. Is somebody going to be able to call 911? So really educating people. And we did this in the hospital. We provided educational materials that are all available through that protocol paper to give to people. And it actually explains all those things too. Yeah.
First, terrific talk.
Thank you.
And congratulations on getting that pharmacy thing fixed in one legislative cycle. That's near impossible.
Not necessarily.
It's a big job. Great job. Is there a sustainable funding model for the mobile services?
Yeah, thank you. I was actually just talking about that with a couple of ID folks last night who are here. And I'm glad you asked that question because you're coming at it. I assume you're a clinician. Yeah. And that's what keeps me up at night, and having to dye my hair every 2 weeks it's just super stressful because it's an actual whole healthcare system. So there's person power, there's are you going to get revenue to sustain this? There's a pharmacy service, there's a lot. So really trying to get buy-in from the healthcare programs like YNHH. So if their goal is to reach other people and we can provide services for other things that maybe not, and I'm saying this from their point of view, not that might make revenue for them. So you could improve access to care. You could help reduce hospital admissions. You could help treat cancer, for cardiovascular disease. We have the Hem/Onc team who's now asking us if we can help reach some of their patients. Again, they're mainly sickle cell patients who can't come in. Are there cardiovascular? We know hypertension, hypercholesterolemia, other risk behaviors. Is there a way to help improve access? So that's what I'm trying to do. It's hard though. And I think about how we can keep it going. And the whole idea was to just evaluate it in Connecticut, develop the model. And could you take either the whole model or parts of the model in other areas of the country? And we really need, every community is going to be different. And I didn't have time to go into this, but there's a lot of boots on the ground work that happened before we brought that into Waterbury, talking to the people, asking them, what do they want? And every community is going to be different. But I was just thinking hospital, you might want to give dalbavancin or radavancin and you need to give them the next injection. Could use that as an opportunity, oncology treatments, et cetera. So, yeah, but it is something that's, I don't know if there's any business model out there and anybody wants to talk to me, feel free. Yeah.
So thank you for your tremendous work. That's pretty amazing what you're doing. My question is around expansion. I think it's phenomenal what you're doing. And you're, like you said, you're in a blue state, in a relatively progressive area. I'm just curious, how do we think this might look in other areas where there's tremendous amount of stigma, a lot of explicit and implicit bias, as well as different political belief systems that may not necessarily support funding healthcare?
Yeah, excellent question. And I didn't have time in this talk, but tomorrow I will talk about that more. But this is I don't know if you could see it, but it's healthcare for everyone. So anyone can walk up to this and get whatever they want. You could, we could park and you could say you want a vaccination. No, and it's not specifically for people who use drugs. However, that would be my goal to help. I'm going to the community. But things about sustainability and where else you could go. So say I have partners in Texas, right? Big problem, not a Medicaid expansion state. Certain services are illegal. Just their difficulty potentially of identifying where to go. But there are aspects of the model that could work. And so my Texas partners are actually now thinking about how they could get a retail pharmacy could they, home treatment and, you know, going to individuals where they're, unhoused, but also those who are housed who can't get out. So, but bias is one of the whole goals of this was to overcome that issue of bias. And I don't have time to go into it, but there are people who are coming back multiple times. Like first they're trying it out. What are you guys doing here? Oh, you do that. Or they hear, I could get a vaccination. I don't need to do this. I don't need to do something to do this. One guy came up and thought we were a certain service program, which I would love to be, but it's very competitive in Connecticut. I said, no, but we could provide treatment. And he had heroin on him. He had to buy it because his wife had his medications for buprenorphine and she was in the hospital. But he thought it was a certain service program and they were able to say, well, we're not, but we can help you, but would you like treatment? And so the clinician could see them, prescribe the buprenorphine, give it to him, treat his withdrawal. So, you know, the long and short is I don't think I know all the answers, but we're working with a lot of groups. And I think every community has got to think about what are the needs and how you can overcome. And it may not be a giant, shiny mobile pharmacy. It may be other things, you know, or components of that we could use.
So we are right up on the hour.
Okay.
Thank you so much. It was a wonderful and inspiring talk.
Thank
And
you.
I know a lot of the people in the room will have a chance to ask their questions as we go through the day.
Thank you very much for having me. Oh, I forgot. I don't know how to end this. Okay. I'll let somebody do that. Thank you. Thanks for inviting me.
Yeah, no, it's great. I've got so many